Good day, everyone. We are the RLE Group B from BSN 1A.
I am Ferdinand Yushuk. I am Fatima Fradeva A. Sensha.
I am Hasmin Claire J. Salimbulang.
I am Sharifa Zara M. Yusuf.
I am Zermlin M. Taji.
I am Muhammad Al-Zain Suhaizan.
I am Aljay Ferpi Yusuf.
My name is Sari Arfad Suri S.
I am Lydia Hairaj Yusuf.
And I am Clarissa Anjay Sajari.
In this video, we will be talking about measuring the blood pressure. We have 3 objectives, which are:
First, we will tell you about the purposes.
Second, discuss step-by-step procedures.
An actual demonstration of measuring the blood pressure of a client.
And lastly, discuss the misconception about measuring the blood pressure. Kindly finish our video for better understanding of our topic.
The purposes of assessing the blood pressure is first, to obtain a baseline measurement of the arterial blood pressure for subsequent evaluation. Second, to determine the client's hemodynamic status. Example, cardiac output, stroke, volume of the heart, and blood vessel resistance.
And lastly, to identify and monitor changes in blood pressure resulting from a disease process or medical therapy such as presence or history of cardiovascular disease, renal disease, circulatory shock, or acute pain, rapid infusion of body fluids, or blood products.
As nurses, to measure the blood pressure of a person or client appropriately, we need to follow the step-by-step preparation and procedure in order to have accurate results.
For the preparation, the first is assessing the client. The second is assemble the equipment.
Going to the procedure, number 1, introduce self and verify client identity using agency protocol. Explain to the client what we are going to do, why it is necessary, and how she can participate. Number 2, perform hand hygiene and observe other appropriate infection control procedure. Number 3, provide for client privacy.
Number 4, position the client appropriately. Number 5, wrap the deflated cuff and locate the brachial artery. For number 6, perform a palpatory determination of the systolic pressure.
Number 7, position the stethoscope appropriately. Number 8, auscultate the client's blood pressure. Number 9, if this is the client's initial examination, repeat the procedure on the other arm. And then number 10, which is the last part of the procedure, is to document and report pertinent assessment data according to the agency policy. So for better understanding of the procedure, we will show you on how to properly measure the blood pressure.
For the preparation, assess signs and symptoms of hypertension, example headache, ringing in the ears, flushing of face, nosebleeds, fatigue. Signs and symptoms of hypotension, example tachycardia, dizziness, mental confusion, restlessness, cold and clammy skin, pale or cyanotic skin. Factors affecting blood pressure, example activity, emotional stress, pain, and time the client last smoked or ingested caffeine. Note, make sure that the client has not smoked or ingested caffeine within 30 minutes prior to measurement. Rationally, smoking constricts blood vessels, and caffeine increases the pulse rate. Both of these cause a temporary increase in blood pressure. Some blood pressure cuffs contain latex. Assess the client for latex allergy and obtain a latex-free cuff if indicated. Second, assemble the equipment. Stethoscope or Doppler ultrasound stethoscope or DUS, blood pressure cuff of the appropriate size, sphygmomanometer. Note, ensure that the equipment is intact and functioning properly. Check for leaks in the tubing between cuff and the sphygmomanometer.
Going to the procedure, First, introduce self and verify client's identity using agency protocol. Explain to the client what we are going to do, why it is necessary, and how she can participate.
So good day, ma'am. I'm Zermilan M. Taji. I'll be a student principal today. So may I ask for your name?
I am Teresa Anjay Sajari,
How about your date of birth?
January 30, 2007.
So ma'am, today I'll be measuring your blood pressure. This is in order to detect any abnormalities. For example, whether your blood pressure is high or low. So ma'am, sit still, then relax your arm, then avoid talking as much as possible, and please do tell me if you're uncomfortable.
Second, perform hand hygiene and observe other appropriate infection control procedures. Third, provide for client privacy.
Number 4, position the client appropriately. The adult client should be sitting unless otherwise specified. Both feet should be flat on the floor. Rationale: legs crossed at the knee results in elevated systolic and diastolic blood pressure. The elbow should be slightly flexed with the palm of the hand facing up and the forearm supported at heart level. Rationale: the blood pressure increases when the arm is below heart level and decreases when the arm is above heart level. Then, expose the upper arm. Number 5, wrap the deflated cuff evenly around the upper arm. Locate the brachial artery. Apply the center of the bladder directly over the artery. For an adult, place the lower border of the cuff approximately 2.5 cm or 1 inch above the antecubital space. Number 6, if this is the client's initial examination, perform a preliminary palpatory determination of the systolic pressure. First, palpate the brachial artery with the fingertips. Then, close the valve on the bulb. Third, pump up the cuff until you no longer feel the brachial pulse. Note the pressure on the sphygmomanometer at which the pulse is no longer felt. Then, release the pressure completely in the cuff and wait 1 to 2 minutes before taking further measurements.
For the number 7, position the stethoscope appropriately. Cleanse the earpieces with antiseptic wipe. Insert ear attachment of the stethoscope in your ears so that they tilt slightly forward. Ensure that the stethoscope hangs freely from the ears to the diaphragm. Place the bell side of the amplifier of the stethoscope over the brachial pulse. Place the stethoscope directly on the skin, not on clothing over the site. Rationale: because the blood pressure is a low-frequency sound, it is best heard with the bell-shaped diaphragm. Hold the diaphragm with the thumb and index fingers. For the number 8, auscultate the client's blood pressure. Pump up the cup until the sphygmomanometer is 30 mm per mercury above the point where the brachial pulse disappeared. Release the bulb on the cup carefully so that the pressure decreases at the rate of 2 to 3 mm of mercury per second. As the pressure falls, identify the manometer reading at carotid cuff phases 1, 4, and 5. Deflate the cup rapidly and completely. Wait 1 to 2 minutes before making further determinations. Repeat the above step once or twice as necessary to confirm the accuracy of the reading. If this is the client's initial examination, repeat the procedure on the client's other arm. There should be a difference of no more than 10 mm per mercury between the arms. The arm found to have the higher pressure should be used for subsequent examination. Last, document and report pertinent assessment data according to the agency policy.
Measuring the blood pressure seems like a check-the-box task, but it is actually a physiological assessment.
Small errors in the technique can lead to significant misdiagnosis. Here are some misconceptions and pitfalls associated with the steps in measuring the blood pressure of a patient.
So the first one is in the preparation and assessment. So many think that if a patient looks relaxed, you can start checking their blood pressure immediately. But in reality, even just by walking to the chair can spike the blood pressure. And taking the blood pressure upon sitting can overestimate the systolic pressure by 10 to 15 millimeters mercury. So the second one is in the positioning of the client, the legs cross habit. So patients tend to cross their legs at knees for comfort. But as the rationale states, this increases the pressure. And the very misconception is that it is just a little bit. But these can actually raise the systolic readings by 2 to 8 millimeters mercury. So the third one is in the cuff application, the one size fits it all. A very common misconception is that the cuff size doesn't matter as long as it stays on. But in reality, using a cuff that is too small for a large arm is the most common cause of a falsely high reading, sometimes up to 10 millimeters mercury. And conversely, using a cuff that is very large for an arm can cause a falsely low reading. So the fourth one is in the preliminary palpatory determination. So many students and pros tend to skip this step and go straight pumping to 200 millimeters per mercury. But skipping this step might risk for missing the auscultatory gap, a period where carotid cuff sounds disappear then they appear. So if you don't palpate first, you might start listening after the gap and underestimate the systolic pressure.
Fifth, positioning the stethoscope. There is a misconception that a thin fabric doesn't affect the sounds. But in reality, the stethoscope must be on bare skin. Clothing dampens the sound or creates friction noise that mimics the carotid cuff sounds, leading to inaccurate readings. 6. Auscultation or the measurement. The most common habit is to drop the pressure quickly to get the procedure over with. But in reality, if you deflate more than 2 to 3 mm mercury, you will likely miss the accurate beat where the sound starts or stops, leading to underestimation of the systolic and overestimation of the diastolic pressure. And lastly, the two-arm comparison. Many believe that it doesn't matter which arm you use. In reality, it is normal to have a small difference, but a consistent difference of 10 mm mercury can be a sign of vascular issues. The misconception is using the lower arm for future checks. You should always choose the arm with higher reading for consistency. And that's all for our video.
Please take note that this procedure was taken from the NDJC 121 manual. Thank you for watching!